Good morning, all. I'm presenting on the topic the Scourge. So, presenting a 53-year-old lady, Mrs. K, a teacher by occupation from Uttar Pradesh, presented to the emergency department with the following complaints: vomiting for 1 month, left-sided loin pain for 1 month, and fever with chills for 1 month. So, the fever was of high grade with chills and dryness, intermittent, and it was relieved with medication. And the last fever was on 15th of August. And the loin pain was radiating to the groin, and it was predominantly on the left side. It's associated with the increased in frequency of micturition and burning sensation while passing urine. So the vomiting, which was there for 1 month, was on and off. The vomiters contain food particles and occasionally saliva. It usually occurs 5 to 10 minutes after taking food. So past history-wise, she had a long course, like in February, she had one episode of pyelonephritis with the E. coli in the urine, and susceptibility was not known at that time. Blood cultures were not sent. So this was in an outside hospital. So she was treated with IV antibiotics and was discharged with the septum 500 BD for 7 days. So then she was quite well till July, and on again in July 3rd, she was admitted for right-sided pyelonephritis, bilateral, with the HUL, right more than left side. So urine and blood cultures were sterile at that time. She was treated with IV antibiotics, and bilateral VG stent insertion was done as she was having HUL. So on 9th of August, she underwent VG stent removal due to resolution of the HUL. So then in 12th of August, again she was readmitted with the pyelonephritis, urine culture isolated CRO E. coli and also yeast. So she was readmitted till 17th of August, and this time she was treated with piptaz and phosphomycin. These are all in outside hospital, followed by oral phosphomycin 3 gram BD at discharge. She also underwent bilateral VG stent insertion for bilateral HUL, which she also had at this point of time. So after that, she was better for a few days, and then again she developed abdominal pain, fever, and vomiting. So she came to CMC for further management. So at this point of time, our differential, because she was having a long course of this pyelonephritis, which was coming on and off, a prolonged duration. So the differentials we considered at that point of time were partially treated pyelonephritis 1, renal abscess which she was having, and then tubercular pyelonephritis and fungal pyelonephritis. So we proceeded with the investigations. CBC was HP of 12 and WBC was 14,300 with the platelets of 2.2 lakhs. So MCV was 82.7 and MCH was 22 and MCHC was 32.5. So LFP, there was no derangement. Urea create, it was also in the normal range, and sodium potassium and bicarbonate was also fairly in the normal range. So urine analysis was showing total counts of 106 per hyperfield and RBC of 14 per hyperfield, and it was also showing yeast cells. So this was the imaging we done for her, which was showing bilateral DG stent in situ. So the initial blood cultures were all sterile for her. So then her urine culture showed Candida tropicalis, and another urine culture also showed Candida tropicalis, and following which the blood culture also showed Candida tropicalis. So all these were susceptible to fluconazole. So she was started with the IV fluconazole 400 mg once daily. So the diagnosis for our patient was candidal pyelonephritis with secondary candidemia. So this presentation was mainly about like how to approach the asymptomatic candiduria. So candidal UTA. So this trial was done in European and non-European countries, where it was found that Candida was the third most common organism isolated in hospitalized patients after Escherichia coli and enterococcal species. So, predisposing factors for this candidal UTI are mainly diabetes mellitus, renal transplant, extremes of ages, and instrumentation of the urinary tract. Next is like colonization versus infection. So when do we say candida as a colonizer is when the patient has candidiuria but does not have any clinical symptoms. When we say it is an infection, they have candidiuria, but along with that, they also have dysuria, frequency, and suprapubic discomfort. But neither the presence of a pseudohyphae in the urine nor the number of colonies growing in the culture will help us to distinguish the colonization from infection. So if they have candidiuria or candida culture growing candida, it is that does not necessarily mean that they are having an infection, but infection is they should have symptoms or signs suggestive of the same. So when they have when a patient has candidiuria, we should repeat urine and microscopy and cultures. So when it is an asymptomatic candidiuria, we should look for like any risk factors for it, like diabetes, renal disease, and genitourinary abnormalities. If they don't have any of that, they can be just kept under observation. But if they have any predisposing condition, manage that predisposing condition, and once it is managed, they can still be kept under observation. Need not necessarily treat the candidiuria per se. So only when asymptomatic candidiuria in a predisposed patient, like when they have disseminated candidiasis, blood is showing candida, or when they are unstable or neutropenic patients, especially when in low birth weight babies, like less than 1,500 grams, they can be they are more susceptible for this candidemia. So in those patients, they have to be treated. Other than those, any asymptomatic candidiuria need not necessarily be treated. So the treatment of choice is fluconazole 400 to 800 mg IV once daily. So when it is a symptomatic candidiuria, we will have to definitely treat for it. So that is also fluconazole 400 mg orally for 4 weeks. So when they have fungal pyelonephritis, the complications they can have are perinephric abscess, fungal ball, which can lead to renal capillary necrosis. So when should we consider imaging in candidiuria? So as I said earlier, when they have persistent candidiuria with the formation of fungal balls, and when they have diabetes, and people who have undergone urological surgical procedures like DJ stenting or any other urological manipulations like cystoscopy, that may predispose them to form fungal ball. And also in neonates, these people can undergo imaging. So when is antifungals indicated in colonization only in neutropenic patients and people who are undergoing hematopoietic stem cell transplantation and solid organ transplantation and surgical manipulation of the urinary tract. So our patient was having urinary tract manipulation in the form of bilateral DJ stenting, and she was also having diabetes mellitus, and because of the fungal ball incident, she was having renal papillary necrosis. So for her, we are treating her with injection fluconazole 400 mg IV OD, and this will be continued for 2 weeks following the first culture negativity. So 30th of August, she had her first fungal culture negativity. So injection fluconazole will be continued for 2 weeks till 13th of this month. She has already become afebrile now. So take home is colonization versus infection, and when to treat colonization and when to consider for imaging in case of asymptomatic candiduria. Thank you.
Thank you. Any questions? I had a couple of questions. What is your comment on the antibiotics the patient received outside?
Yes, sir.
Patient had a carbapenem-resistant E. coli.
But still she was given this.
Sorry?
Yeah, carbapenem-resistant organism, but still she was not adequately treated. For
you said she was treated with piperacillin, tazobactam, and fosfomycin. You think that's a good choice? Or?
No, sir. It was not.
What would you have chosen?
Polymyxin would be a better option, sir.
Polymyxin or?
Colistin.
Because polymyxin would not achieve urinary concentrations.
Yes, colistin.
Perhaps colistin. Right? Or anything better than colistin in this situation? This is E. coli. This is not Acinetobacter. Maybe ceftazidime-avibactam plus minus aztreonam based on the susceptibility testing that has a higher efficacy than. So that's one thing. You said the risk factors in this case, no? Where for Candida, one is also this broad spectrum antibiotics. So you received multiple courses of broad spectrum antibiotics, and such patients are predisposed as well. So that's the other predisposing factor as well. If you said an unstable patient, so I'm sure if you had a asymptomatic patient, that's fairly straightforward. What if the patient was sick, like for example, is having fever, is in the ICU perhaps on inotropes, and then this urine culture grows Candida. How will you then decide what to do to treat it or not? Which is a fairly common occurrence.
So we'll have to see, if there are no other organisms growing, and if only Candida is the susceptible organism causing their illness, then probably we should chase it. So. Yeah,
so I think the first point is you're right. If there's no other explanation for the fever and shock and things like that. The other thing is here. So again here, you'll have to identify whether it's actually causing a pyelonephritis. It's very difficult to do that. So clinically, if there is any signs of pyelonephritis, or here this is an indication where you might want to image the kidneys and see whether there's any evidence of pyelonephritis. So if there is, then you can treat it. Otherwise, if the patient, you can decide what the risk is. If you have an alternate explanation for the fever, then you can let it go and wait and see. Otherwise, if there's no other explanation, then you might want to treat it. So it's a little difficult in such a patient. Okay. Thank you. Next we have